Hello students, welcome to EPG Pathshala. I am Rashmi Sinha from Indira Gandhi National Open University. Today we are going to talk on module Healthcare Delivery in the Public and Private Sector from the paper Human Growth, Development and Nutrition. In this module, our learning objectives will be to learn the definition and scope of healthcare system, to know the models of healthcare systems, the evolution of healthcare system in India, to understand the healthcare system in India. You will also get educated on the components of healthcare systems evaluation. A health system or healthcare system is the sum total of all organizations, institutions and resources that deliver services to cater the health needs of target population. Healthcare systems are influenced by each nation's history, traditions and political systems, resulted into variations in healthcare system throughout the world and contributed to different types of social contract between citizens and their countries. It operates in the context of socio-economic and political framework of the country. In some societies, healthcare system is viewed as social good demanding benefits to all stakeholders, whereas in other societies, it is considered as a commodity to be owned by payments. In the world scenario, four types of healthcare systems are observed. They are Beveridge model, Bismarck model, the national insurance model and out-of-pocket model. This classification is based on the source of funding. Models of healthcare systems. The Beveridge model, also called socialized medicine model, was proposed by Lord William Beveridge. This model is a public healthcare model wherein the health services are provided through national health services. The fund for the services is provided by the government by levying taxes on public. This model is in use in the countries like United Kingdom, Spain, New Zealand and Cuba. The Bismarck model is named after the Prussian Chancellor Otto von Bismarck. The funding for services is provided through an insurance system by employees and employers through payroll deduction. Doctors and hospitals are private in nature. This model allows flexibility in spending money on healthcare. The countries that follow this model are Germany, France, Belgium, Netherlands, Japan and Switzerland. The national insurance model was proposed by Tommy Douglas. The services are provided by private people but financed through a government-sponsored insurance program which requires that every citizen pay through premium of tax. This model is practiced purely in Canada. The out-of-pocket model is found in countries where there are no healthcare systems to meet the health needs of citizens. In this model, those who can afford get the health care and those who are unable to pay stay sick or die. Rural areas of India, Africa, China and some South America are the example of this type of model. Evolution of healthcare system in India. It was reported that preventive and curative care practice in centers equivalent to modern day health centers were existed during the period of Emperor Ashok. Existence of teaching hospital at Nalanda University equivalent to modern day health centers were also cited in literature. The health services commitment to the people of India was made in the directive principles as a state policy. The Bhor and later Mudaliar committees made recommendations for comprehensive, preventive and curative services under the leadership of skilled clinicians. The Chopra Committee advocated exchange of knowledge between allopathy and Indian system of medicines, and the Sukhe Committee enlisted the requirements of skilled persons from grassroots levels. India launched family planning in 1952, initially targeted for birth control, later focused on maternal health, maternal child health, nutrition and family welfare. Departments of social and preventive medicines were commissioned following the recommendations of Medical Education Conference held in the year 1955 to bring social orientation in medical education. The Indian Public Health Association was started in 1958. The number of beds and urban dispensaries were increased. The National Malaria Control Program was started in 1953 and the Smallpox Eradication Initiative was made in the year 1963. The BCG vaccination to cover entire population was also attempted in 1973. Srivastava Committee has proposed a three-tier approach for rural healthcare in 1975. Government of India started Rural Health Scheme in 1977 using village level, sub-center and primary health center approach to manage rural people health. The programs against leprosy, filariasis, trachoma and cholera were also launched by the Government of India. The Integrated Child Development Program was started in 1975 for the children aged less than 6 years to provide preventive services and non-formal education. In pursuit of health for all, Government of India proposed National Health Policy in 1983 with specific goals for the next 15 years under the framework of 5-year plan. The National AIDS Control Organization was launched in 1992 as a division under the Ministry of Health and Family Welfare to formulate policy and implement preventive and control programs of AIDS in India. Department of Indian Systems of Medicine and Health was commissioned by Government of India in the year 1995 under Ministry of Health and Family Welfare and was rechristened as Department of Ayurveda, Yoga and Naturopathy, Unani, Siddh, Homeopathy in the year 2003. This is called Ayush. In the year 2002, National Health Policy was presented by the Government of India with an objective of attaining acceptable standard of health in population and emphasized on increasing access to public health systems by establishing new infrastructure in deficient areas and upgrading infrastructure in existing institutions. The new National Health Policy of 2015 was drafted by Government of India. This document is in circulation for comments with the goal of attaining the highest possible level of good health through preventive and promotive healthcare orientation and increased access to good quality healthcare services without financial hardships. Healthcare system in India. In India, healthcare system is organized into 5 sectors or agencies based on application of health technology and sources of funds for operation. Number 1, public sector. Under this, primary health care is there, in which primary health center and sub-centers. Then comes hospitals health center. Under it are community health centers, rural hospitals, districts hospitals health centers, specialist hospitals, teaching hospitals. Then there is health insurance scheme. Under it comes employees state insurance, central government health scheme. Then other agencies like defense services and railways. Second source is private sector. 1. Hospitals, polyclinics, nursing homes, dispensaries to general practitioners. The third source is the indigenous system of medicine. 1. Ayurveda and Siddha, Unani and Tibbi, homeopathy, and the fourth is unregistered practitioners. Fourth, voluntary health agencies. Under it are Indian Red Cross Society, Hind Kushant Nivaran Sangh, Indian Council for Child Welfare, Tuberculosis Association of India, Bharat Sevak Samaj, Central Social Welfare Board, the Kasturba Memorial Fund, Family Planning Association of India, All India Women's Conference, the All India Brain Relief Society, the Indian Medical Association, the All India Licentiates Association, All India Dental Association, the Trained Nurses Association of India, the Rockefeller Foundation, Ford Foundation, care, cooperative for assistance and relief. Then there is national health programs. Under it are National Vector-Borne Disease Control Program, National Anti-Malaria Program, National Filaria Control Program, Kala Azar Control Program, Japanese Encephalitis Control, Dengue Fever Control, National Leprosy Eradication Program, Revised National Tuberculosis Control Program, National AIDS Control Program, National Program for Control of Blindness, Iodine Deficiency Disorders Program, Universal Immunization Program, National Rural Health Mission, Reproductive and Child Health Program, National Guinea Worm Eradication Program, YAWS Eradication Program, National Cancer Control Program, National Mental Health Program, National Diabetes Control Program, National Program for Control and Treatment of Occupational Diseases, Community Nutrition Program, National Surveillance Program for Communicable Diseases, Integrated Diseases Surveillance Project, National Family Welfare Program, National Water Supply and Sanitation Program, National Program for Prevention and Control of Deafness. Primary health centers, that is the PHC, covers 1 lakh population spread over 100 villages. 1 medical officer, 1 block extension educator, 1 female health assistant, 1 compounder, 1 driver, and 1 laboratory technician staff them. At PHC, minimal procedures like tuberculotomy, vasectomy, medical termination of pregnancy, and minor surgical procedures are carried out. As on September 2005, 23,236 PHCs were functioning in India. As per Medical Council of India, 3 PHCs should be attached to 1 medical college. Community Health Center is an upgraded PHC covering a population of 80,000 in hilly, tribal or desert area and 1,20,000 population in plain area. This unit is 30-bedded facility covering specialties like medicine, obstetrics and gynecology, surgery, pediatrics, dental and Ayush. As on March 2010, 4,535 community health centers were functioning in India. These specialists in community health centers may refer a patient directly to state level hospital or to the nearest appropriate medical college hospital as may be necessary without the patient having to go first to the subdivisional or district hospital. Other types of hospitals which come under the purview of public sectors include rural hospitals, which are proposed to cover a population of 5 lakhs. District hospitals have curative services and no target population. Specialist hospitals like chest hospitals and teaching hospitals like the medical colleges and institutes. Components of healthcare system evaluation. 1. The evaluation of goals, that is the patient's safety in medical procedure, effectiveness in interventions, availability of timely care, personalized patient care based on patient's need, values and preferences and efficiency in healthcare and equity. 2. Investigation of application of tools, that is the evidence based on the treatment and outcome management system. 3. Assessment of quality of care, that is the structure, process of care, outcomes, audit and quality assurance, appropriateness, inappropriateness and quality of life. Efficacy. It is evaluation of interventions in improving the clinical outcomes. Efficacy is evaluated by using randomized clinical trials, the RCT. RCTs are applied in case of medications. RCTs were never used for testing efficacies of surgeries, clinical setups like intensive care units, medical devices, and nursing staff decision. For example, patients diagnosed with herpes zoster were randomized in 2 groups based on rashes duration of less than or greater than 72 hours and were administered Acylovir 800 mg 5 times a day for the first 4 days, followed by 3-day treatment-free days. The second course was followed with the same dosage when there is an evidence of pain reduction but not complete pain response. These patients were followed for 3 months without medication. The severity of symptoms of herpes was evaluated using 4-point verbal rating scale. No significant difference in efficacy of treatment between the groups was observed. Effectiveness. The study on the effectiveness is undertaken when the particular intervention is efficacious. In general, for most of the treatment, there is no evidence of efficacy but accepted as common practice. Effectiveness in health services and cost of care can be compared using randomized clinical trials. 2 or more groups were included in RCT to ensure comparability and to avoid selection bias. Effectiveness research is being carried out in community settings. For example, cost effectiveness of ivabradine. Cost effectiveness of ivabradine was compared using Markov model in 2 groups of heart failure patients who were in sinus rhythm, left ventricular systolic dysfunction, and a baseline heart rate was either greater or equal to 75 or greater or equal to 75 beats per minute. Ivabradine in combination with standard care including beta blockade was found to be cost effective than standard care alone in HF patients. In the absence of evidence of equivalent nature of treatments, RCT is used to compare the effectiveness of treatments. For example, weight loss intervention. 415 obese persons were divided into 3 groups: control, online intervention, that is on the telephone, email, or web page, and in-person intervention, that is in a group or individual sessions in randomized controlled trials, and were studied for a period of 1 year. The weight reduction in control, online intervention, and in-person interventions were 1.8 kg, 4.6 kg, and 5.1 kg respectively. In non-randomized studies involving groups receiving different treatments, risk adjustment is done. For example, in comparison studies, the adjustment of factors affecting the outcome explain the variation among the groups. The non-equivalent groups are compared to know the effectiveness of alternative treatment, impact of poor access to care, and to assess the cost effectiveness of each provider. For example, cost effectiveness of soft tissue injury management. Patients with soft tissue injury presented to the emergency department were randomized for management to nurse practitioners, extended scope physiotherapists, and to routine care to doctors. No difference in clinical outcome was observed, but the management by the practitioners other than doctors was found to be cost intensive. Operation reach methods also used to compare provider practices, health plans, and to control the cost of health care. These methods are used in designing payment systems and resource-based relative value scales. The latter are useful in standardizing patients with care in outpatient settings. The sources of data for effectiveness research are case sheets, billing data, and survey questionnaire. If patients don't follow up care and approach multiple providers, care sheets are of limited use. The drawback of billing data is lack of clinical data. The effectiveness of survey questionnaire depends on the patient recall. Evidence-based treatment at outcome management system. Healthcare services research tools like evidence-based treatment and outcome management systems are used to improve the clinical practice and patient outcomes in settings like hospitals, clinics, and health plans. Evidence-based treatment information available in literature provide a criteria for quality care to judge the current practices. For example, evidence-based treatment information has shown the benefit of antihypertensive drug treatment in reducing the health outcomes in patients with hypertension. The reasons cited for non-conformance with evidence-based treatment were physicians' disagreement with the evidence, perception that patients will not accept the treatment, low rating of efficacy of the treatment by the provider, and inability to integrate the evidence-based treatment into existing practice. Elwood in 1988 has proposed outcome management system as a method to build clinical intelligence on the application of treatments. In this method, along with outcomes of care and information on diagnosis and treatment, experience of patient is documented. For example, evaluation of chronic kidney disease, that is CKD management on the clinical outcome. Two groups of patients, group 1 which were the CKD management and group 2 without CKD management, were evaluated for access to nephrology care, trends in renal replacement therapy, starting modality and place of death without RRT, that is the renal replacement therapy, for observation period of 2003 to 2012. 91% of patients known to the nephrologist, RRT incidence peaked in 2005 and then declined. Percentage of patients undergoing transplant, hemo or peritoneal dialysis was increased to 63% in 2012. 52% of patients receiving standard care without dialysis were reported to die out of hospital. Incidence of RRT, the renal replacement therapy, and modality of initiation of RRT improved in patients who were under CKD management, that is the chronic kidney disease management. Quality of care. Quality of care is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. The main emphasis of quality of care is increasing the likelihood of achieving desired outcomes in patients' perception. Donabedian in 1991 has proposed the conceptual model for describing, analyzing and evaluating the quality of care using the dimensions of structure, process of care and outcome. Quality assurance and audit have been shown to maintain quality in healthcare. Evidence of improper administration of injections by the physician prompted research on the appropriateness of the procedure. Research and variation in care suggested inappropriateness of care. Structure. Structure of healthcare system includes infrastructure, that is the buildings and the bed, manpower, which is clinical and paramedical, and technology, that includes the equipments. For accreditation of healthcare services, the structure is one of the components taken into consideration. Structural aspects also influence the quality of healthcare services. The data on structure is collected using questionnaire and analysis of documents. Utilization of services and outcome of care. Process is evaluated by applying 6 goals of healthcare like patient safety, timely care, treatment confirming the evidence-based practice, patient-centered treatment, efficiency of care, and equity. This analysis will help to know whether improvement is required and where efforts should be directed. Process involves collection of data on interaction between professionals, provider, and patient, plans followed and documented. The range of data collection covers rates of hospital discharge, number and type of medications given, number and type of interaction between providers and patients occurred, number of hospital visits made, average length of stay, length of consultation, medical and surgical intervention rates, waiting list, waiting times, and accessibility. The data for process of care is collected from medical records, computer databases, and using survey questions. Outcomes. Outcomes are the effects of health services on patients' health as well as patients' evaluation of their health care. Data on outcomes of health services are useful for audit and for purchasing policies. Health outcome measurements include disease progression, patient-reported health status or functional status, satisfaction with health status or quality of life, satisfaction with services, cost of health care, survival periods, biochemical indicators or symptom rates, relapses, various indicators of physical and psychological morbidity, number of bed days, and hospital readmission rates. Evaluation of treatment and care should be done to check whether they are leading to outcome worth living in social, psychological, or physical terms. The outcome should also incorporate patients' perceived health status, quality of life, and patient satisfaction with the treatment. Audit and quality assurance. Audit is the reviewing and monitoring current practice and evaluating the predefined standards are met. Audit is of two types, medical and clinical. Medical audit analyzes the quality of medical care like diagnosis and its procedure, clinical decisions about the treatment, use of resources and patient outcome. Examples are analysis of avoidable deaths, assessment of medical decision making, resources and procedures used in relation patient outcome. Doctors and paramedical staff conduct the clinical audit and analyze the clinical care review, the diagnosis and its procedure, clinical decisions about the treatment, use of resources and patient outcome. Quality assurance involves the monitoring and evaluation of predefined and agreed levels of services guidelines. The main goal of quality assurance are getting guidelines and evaluation to improve performance. Audit is done by analyzing documents, clinical case reviews, collecting information on patients and patient-assessed outcomes using questionnaire. Appropriateness. There is no internationally agreed definition on appropriateness in health services research. Much emphasis was given on the appropriateness of interventions. All stakeholders, that is the providers, patients and policymakers in health services research attempts to identify appropriate treatment and services to deliver, assessment of the outcome, estimate the level of need in the population for the intervention and evaluate their provision and mode of delivery. Appropriateness may also include organizational factors, for example, length of hospital stays. Inappropriateness. Increased evidence on inappropriateness prompted investigations of health outcomes and appropriateness of interventions. There is an inadequate research on appropriateness of many medical interventions. High level of inappropriateness and wide variations in the practice of procedures were observed in various countries. For example, high level of inappropriate rates in surgical interventions of coronary heart diseases in USA and wide variation in the practices of various procedures in UK were reported. Health-related quality of life. Health-related quality of life scales measures the impact of disease condition and treatment on the person's emotional, physical and social functioning and lifestyle. HQOL represents patient subjective evaluation of quality of life of disease condition and after medical and surgical interventions. Disease-specific quality of life scales can be useful in assessing clinically significant changes and level of disease severity. In subjects with multiple health problems, generic health-related quality of life scales are useful. Let us summarize what we have learned in this module. A health system or a healthcare system is the sum total of all organizations, institutions, and resources that deliver services to cater the health needs of target population. Healthcare systems are influenced by each nation's history, tradition, and political system. Healthcare systems are categorized into Beveridge model, the Bismarck model, the national insurance model, and the out-of-pocket model based on the source of funding. In the Beveridge model, the health services are provided through national health services. The fund for this services is provided by the government by levying taxes on the public. The funding for the services is provided through an insurance system by employees and employers through payroll deduction in the Bismarck model. The countries following this model are Germany, France, Belgium, Switzerland, Netherlands, Japan. In the national insurance model, the services are produced by private people but financed through a government-sponsored insurance program which requires that every citizen pay through premium on, or tax. The out-of-pocket model is found in rural areas of India, Africa, China, and South America, where those who can afford get the health care and those who are unable to pay stay sick or die. There are evidences of existence of preventive and curative practice during the reign of Emperor Ashoka and the teaching hospitals equivalent to modern medical colleges at Nalanda University. The modern healthcare system of India evolved using the inputs of various committees headed by Bore, Mudaliar, Chopra and Srivastava. In India, healthcare system is classified into 5 sectors or agencies based on the application of health technology and source of funds for operation. Components of health services, health system evaluation include healthcare system goals, patient safety in medical procedures, effectiveness in interventions, availability of timely care, personalized patient care based on patient's need, value and preferences and efficiency in healthcare equity. Then the application tools, that is the evidence-based treatment and outcome management system, and quality of care, that includes structure, process of care, outcomes, audit and quality assurance, appropriateness, inappropriateness and quality of life. Thank you.